I know I did talk about previous symposium, and this has to be presented by my colleague, Professor Mirvat Abulmaati, but for time's sake, and I'm presenting it at the moment. So let's go for the topic of the title, which is Triglycerides Inertia, the forgotten cardiovascular risk. Treat often, cure sometimes, comfort always, and harm nothing. I do believe in this quote too much, actually, and this according to Socrates. My presentation is mainly taken from many review articles, and those are the main review articles from European Society of Cardiology, JAC, and New England Journal of Medicine about the clinical and critical review of triglyceridemia or triglycerides. This table shows the normal and slightly abnormal and highly abnormal values of triglycerides. And I'm very honored to have Professor Mirvat Abulmaati in front of me at the moment. So the leading cause of death worldwide is coronary artery disease, on top of the different chronic illnesses worldwide. It remains, cardiovascular disease remains the first cause or number one cause mortality worldwide, and this is clearly because of that. Aggressive atherosclerosis. Atherosclerosis is a chronic inflammatory disease of the medium-sized arteries, and is associated with significant morbidity and mortality. Some studies suggest that it starts at the age of 2 years old. Vietnamese Americans, when they were in Vietnam, they did post-mortem studies, and they found that even children with familial hypertriglyceridemia, actually they have some fatty streaks and initial plaques in their medium-sized arteries as age of 2, 3, and 5 years old. So this is the level of triglycerides. Pointer is not working, and you can clearly see that from main trials, ProCam, Copenhagen, Lipid Research, Helsinki, LTS, and Framingham trials, that generally speaking, hypertriglyceridemia is either independent risk or very high risk when combined with this lipoproteinemia for high LDL as coronary artery disease risk factor. So either alone or combined with dyslipidemia, high level of triglycerides is associated with significant morbidity and mortality and high prevalence of coronary artery disease. There are many cumulative risks in MI, ischemic heart disease, in women and in men, and you can clearly see that for those who have high levels of triglycerides, they have more prevalence, more mortality, and more morbidity as well. This is another one, I think, from Framingham trial. This is one of the largest, longest studies worldwide studying the risk factors of G1, G2, and G3 now risk factors of cardiovascular disease and atherosclerosis. Again, it reveals that high levels of triglycerides is associated with significant risk of morbidity and mortality and coronary artery disease. Again, in diabetics, it's the same, and even is more worse and more severe in patients with diabetes mellitus type 2. So there is increased risk in patients from USA database with triglycerides, which is 2.26 to 5.6, which is, more than 150 milligram up to 500 milligram. And the risk is extremely high when it exceeds 500 milligram per deciliter. And this is here the risk of pancreatitis. So the mortality here is from different perspective. So this is the effects of incident hypertriglyceridemia in USA citizens, and you can clearly see that coronary artery disease, peripheral arterial disease, coronary artery disease mortality and morbidity is associated with higher levels of hypertriglyceridemia. Statins do work on LDL and to a very less extent on triglycerides. Clearly speaking, they do not work mainly on triglycerides or HDL, which is non-LDL cholesterol, which sometimes is overlooked or just forgotten in the management wings of coronary artery disease. We do focus on LDL, which is right, but we have to focus as well on reducing triglycerides levels and try to improve or increase the levels of HDL. So even with tight control of LDL, there is still a relative risk reduction and a relative risk gap in the prevalence of coronary artery disease. Again, in diabetes, hypertriglyceridemia is associated with significant risk of coronary artery disease. So elevated triglycerides is associated with high risk of coronary artery disease, and this is how hypertriglyceridemia lead directly and indirectly to increased prevalence of coronary artery disease and morbidity and mortality related to coronary artery disease. So even if LDL is low, but you still have high levels of triglycerides or very low levels of high HDL, you still have a residual risk of coronary artery disease. So the risk of coronary artery disease is high worldwide, different regions, different meta-analyses regarding the triglycerides and coronary artery disease risk. You can clearly see here that elevated triglycerides with low LDL represent greater risk even in diabetic patients. There is a large population study of the US which proven the same, that hypertriglyceridemia is related to coronary artery disease. Diabetic dyslipidemia is somehow different from any conventional dyslipidemia, because in diabetic dyslipidemia, the proportion between apolipoprotein A and the LDL particles is disproportionate, which leads that with even the lowest number of LDL, you still get a high risk of coronary artery disease. And this is why diabetes mellitus is a coronary artery disease risk equivalent. Same. So if you, Mr. X or Y, has diabetes, actually, they look like having coronary artery disease, even in absence of significant coronary artery disease. So it's something challenging, and this warrants further management and concern about management of dyslipidemia. There are many reviews and prospective studies of value of reducing triglycerides in patients with hypertriglyceridemia and the role of phenothyroid as an important particle that lowers triglycerides, defragmented, and reduce the level of hypertriglyceridemia in different patient categories. However, the new particles or small particles of phenothyroid actually work more effectively in reducing hypertriglyceridemia. As you can see here, that phenothyroids in particular could be conjunct or added as add-on therapy to statins in management of hypertriglyceridemia and dyslipidemia. And this was actually readdressed many times in different trials. So reducing triglycerides actually reduces microvascular and macrovascular complications associated with hypertriglyceridemia, as you could see here very clearly, that both microvascular and macrovascular complications are reduced when you reduce the level of triglycerides. So phenothyroids has been extensively studied in patients with hypertriglyceridemia, in patients with type 2 diabetes, and it was associated with reducing hypertriglyceridemia triglyceride levels and reducing the risk of coronary artery disease. So Accord lipid adding fenofibrate to simvastatin significantly reduced the risk of LDL and the triglyceride levels in patients with coronary artery disease, and this was studied over years of follow-up in patients with hypertriglyceridemia and dyslipidemia, and this was extended for Accord 1 and Accord 2 trial. So combining fenofibrates with rosuvastatin further improved triglycerides and improved HDL level in patients with type 2 diabetes mellitus. So in DACE trial, fenofibrate significantly reduced progression of atherosclerosis by reducing both triglycerides and LDL and improving the numbers of HDL in patients with hypertriglyceridemia. So the conclusion was that fenofibrate significantly slowed progression of focal atherosclerosis 40% at least in patients with hypertriglyceridemia when compared to placebo. So the observed reduction in angiographic progression of coronary artery disease was reflected on patients' outcomes. So fenofibrates added to statins in patients with diabetes or even without diabetes could reduce the risk of coronary artery disease and its complications, and they are targeting mainly triglycerides and LDL particles. So I will not go extensively on that, but you can clearly see the difference between conventional fenofibrates and the particle fenofibrates, which is 160 milligram. Both of them, they work on triglycerides, but more effectively, 160 milligram work without GI symptoms and actually without reducing its efficacy in reducing triglycerides. We have many trials. I'm not going to go through them, but according to the guidelines, as you see here, measurement of lipid profile should be for fasting state, especially if you are looking for triglycerides. So nowadays, most of us, they do lipid without fasting, but appropriately, if you want to measure LDL precisely, triglycerides precisely, let the patient fast at least for 10 to 12 hours. So in adults who are 20 years of age or older, if the initial triglycerides levels is high, you have to repeat while they are fasting. That's very important. And if you see here, it's recommended first to treat hypertriglyceridemia with the maximum tolerable statins dose. If you reach the maximum tolerable statin dose without side effects and you didn't reach the target LDL, which should be then less than 200 milligrams, and in some reviews less than 150 milligram to reduce the risk at all. So you have to add fenofibrates for patients as class 2A regarding adding fenofibrates. You can see that in 2P, that primary prevention, so we were talking about secondary prevention. For primary prevention, it's 2B to add fenofibrates in consideration of primary prevention in patients with hypertriglyceridemia and dyslipidemia. So my take-home message, hypertriglyceridemia is a very dangerous disease because it's associated with significant progression of atherosclerosis. And according to the guidelines, we have to address the target of triglycerides beside addressing, of course, the major target, which is LDL reduction. You still have the option and the room to add fenofibrates to statins in management of different types of dyslipidemia, especially in diabetic patients. My take-home message, despite achieving LDL goals with intensive statin therapy, the residual vascular risk remains high in most patients. Patients at increased risk despite maximum statin therapy usually have low HDL and high triglycerides level. Elevated triglycerides should be targeted in all diabetic patients as primary prevention and in all patients for secondary prevention. Fenofibrates 160 milligram is still a valid option for management of hypertriglyceridemia in diabetics and in non-diabetics. Thank you once more. Thank you for being with us today in ICRA 2020.